Any other instruction from your side?
No, nothing at all.
Take it. Absolutely.
Yeah.
Saran,
One thing,
GSK,
my voice tends to get very low.
no problem.
That happens, just prompt me to
GSK
speak.
sir wants to join. Yeah. Right, sir. Hello.
Prompt me to speak loudly.
Okay, sir.
पासवर्ड वर ज्या जिथे पासवर्ड मागते तिथे टॅप करा फक्त. It's a open password, Shyam.
My voice tends to get very low.
हा, पासवर्डच्या ठिकाणी फक्त टॅप करा सर तुम्ही. Right, sir. Hello.
Prompt me to
Hello.
speak loudly.
Yes, sir.
पासवर्ड फक्त टॅप करा. पासवर्ड ज्या जिथे पासवर्ड मागते तिथे टॅप करा. It's a open password.
Yeah, it is open password, sir. Ask them to close the Zoom first and then retry.
Do one thing. Close the Zoom. Zoom close करा. Zoom मधून नका उघडा तुम्ही सर. फक्त मेलला टॅप करा. बस मेलला जिथे लिंक आहे तिथे टॅप करा. That's all.
Yeah.
हॅलो. हो, एक काम कर. Zoom क्लोज कर. पहिले Zoom क्लोज कर. Zoom क्लोज करून लिंक पर टॅप कर फक्त बस. Zoom च्या बाहेर ये आणि लिंक पर टॅप कर. Is it live on TV now? YouTube?
It is YouTube live.
We can mute it for a few minutes till we get.
Yeah, we can. Yeah. It's already muted.
Muted, no? Okay. Jamle? Hello?
Yeah.
No, we are waiting for GSK sir to join.
Sir. It's okay? Can we put, sir, your first slide of your introduction or the CV slide?
It's already up.
This is the second slide we are seeing.
This is the title slide.
Yeah, before that your CV slide, if it is there, it helps. Those who are joining internationally, they.
I got only this before.
Yeah, even that would be fine. Even that would be fine. Hello, sir.
Yeah, I think he is joining. Yeah, GSK sir has joined.
You have joined, sir. That's fine. Perfect. So we can start. This is already exact 2:30.
Yes.
Right. GSK sir, you are comfortable?
1 minute, huh?
Yes, sir.
You must be seeing Anand Thakur, sir. Anand Thakur, sir, can you put more light on your face?
No, we tried that, but
I'll try.
Just try.
हे बरोबर आहे.
Does that work?
Fine. That's fine. Perfect. Ashok, linked up and we can go ahead.
Yeah, linked up and we can go ahead.
Good afternoon, friends. This is a series of webinar during this lockdown period, and we are fortunate to have Dr. Anand Thakur with us, who would be putting his heart out on the topic of locking compression plates. So whenever we use a LCP, a lot of thoughts in mind. How much span, what configuration. So all these fundamentals, he is very sound in his fundamentals about locking plate fixation. And I have heard his lecture, and that's a tremendous lecture. So we are all fortunate to have Dr. Anand Thakur. And we are also fortunate that Dr. G.S. Kulkarni is with us as an expert for his expert comments. And the process would be, we'll be starting immediately with Dr. Thakur's lecture. In between his presentation, he will be giving us opportunity to ask questions. So at a particular time in his presentation, he will be showing when to ask questions. And at the end also, we'll be taking up all the questions. And we have enough time with us. So we are ready to go. I welcome Dr. Anand Thakur sir. I welcome Dr. Ashok Sham, who has given us this wonderful platform. And I welcome Dr. GSK sir. And welcome all the listeners and fellow colleagues all over India and abroad. Welcome for this wonderful opportunity to listen to Dr. Anand Thakur. Thakur sir, most welcome.
Good afternoon. We have been using locking plates since year 2000. That was the year when they were introduced. And over the last 20 years, we have experimented with them. We have learned more and more about them, and now we are more confident about using them as and when required. What started as a novelty has now become a necessity and everyday use. So it's good to know what's happening to that. But before we go into that, I want to just recapitulate a few definitions. A relative stability we use all the time is a fixation of a fracture that allows a small amount of motion when it is loaded. This leads to once there is a motion, there is always a callus formation at the fracture site. Another definition is absolute stability. When the fracture is so fixed that it does not allow any displacement, then we call it as absolute stability. When this happens, the general mechanism to make a callus in the body stops working. It is sensitive to mechanical stimulus, and when there is absolute stability, it just stops working, and we do not see callus formation. The bone healing takes place by direct primary bone healing method. Strain is another term that we come across very often. It is a ratio of change in the fracture length to the original length. So the change could be lengthening or it could be shortening when it is loaded. When there is a load, there is a pressure. If it becomes shorter, it is still strain. If it becomes longer by pulling, it still becomes strain. Just to give an example, the top, here is the first fracture, and we are elongated it. It stretches to a certain level, and we say there is a strain of so much. The difference between this position and this position, we take out a percentage and say this is about 10%. If we stretch it too much beyond 10%, it may break, and then the healing does not occur. Similarly, if we put a pressure on it, load it too heavily, and the fracture line becomes smaller, then there is no movement. The strain is very low, less than 2%. Formation stops, and we do not see fracture healing by method of callus. Primary bone healing starts that way. So the strain could be in lengthening, also in shortening. There are units that is expressed as percentage of the change. That means it is changed by 2%, it has changed by 10%, it is less than 2%, or it is more than 30%, something like this. There are no units to that. Well, stiffness is another term, is the ability of a material to resist deformation. You have made a construct and you have loaded it. If it is resist your loading, that means it is stiff. It has got a good stability. If it is weak, it collapses, then it is flimsy, it is not stable, it is not stiff enough to take the loads that we are doing. The standard method steps of bone healing are inflammation, soft tissue, remodeling, and we are all very well aware of that. And these are done by either osteogenic cells which grow on a osteoconductive scaffold, and there are stimuli by way of hormones or chemicals that will stimulate the growth or stop the growth as required. Only recently we are now identifying mechanical environment as the fourth organ or fourth force that will control the formation of callus in a fracture site. The mechanical environment is very important, and that is what we can control, and we can do that. As surgeons, we have full command over mechanical environment, and that is where we need to put in our mind. when we just heal, treat a fracture either in a splint or a traction or a cast, the natural healing process takes place and you can see abundant callus. Issue is with this, there is many times or usually either malunion or a deformity or the muscle wasting happens and also fracture disease has been described as a thing of past, but that is what prompted surgeons to start operating on fractures, and we started doing internal fixation. The aim of internal fixation was to get anatomical reduction so the joint could be moved immediately. And as the surgeons started developing it, the method was perfected, and they came to a procedure where they could produce absolute stable, perfectly stable, absolute stability. As a result, we got primary bone healing, which is a byproduct of our technique. In nature, primary bone healing does not take place. It's only in the treated fracture it takes place. So it's our gift to nature. So what is the purpose of internal fixation? When we undertake, what we want to see then is quick healing with bone callus formation. And we get that so that we can mobilize that fracture very early. Our desire is always to see callus so that we know that healing has occurred and we can now mobilize the patient. We also want, by our skills, want to see that the strain does not go below 2%, because we now know that if the strain is less than 2%, there will not be callus formation. And if the fixation is very flimsy, not stable, it will break down. There will be too much movement, there will be too much strain, more than 10 or 12%, and the fracture, the callus will not form and we'll have a non-union. So we always want to achieve some level where the callus is formed, and that is between 2 and 10% of the original length of the fracture, which we now know as relative stability. We all know the biological causes of non-union, like infection, severity of injury, peripheral diseases, diabetes, irritation, and other things. Smoking, of course, smoking is another cause. So these are the ones which are there, but there are other significant causes which should worry us. Poor surgery, with our own, with iatrogenic causes, increased injury to local soft tissue, poorly controlled dissection, causing more damage than what the original trauma caused. This is a significant cause of bad outcome of non-union. If we apply a very stiff plate, very thick plate with very large screws and very many screws, then there is no movement at the fracture site. the moment, interfragmentary motion is less than 2%, then we have issue. There is dealing. If we destroy too much periosteum, the vascularity is destroyed and we produce inappropriate strains at the fracture site, either too less or too much. And then this is cause, which is entirely controllable, which is in our hand. And many times we are the cause of this reason. And so look at this, you can't blame anybody except the surgeon and his methods and his technique. What else can you blame on? So we should avoid this kind of happening. Whenever we start, we want to achieve appropriate strain levels. That is the aim of our internal fixation. Here is a fracture which was treated with plating with adequate gap and fixation, which produced 2 to 10%, and in desired time the fracture healed very well, and you can see the results. Another fracture which requires application of compression, and to produce this, first we consider that we will use the DCP, which is nowadays the standard apparatus to produce, but I was skeptical that we may not be able to produce adequate compression at the fracture site, so we will not get adequate stability for it to proceed. I had this patient in mind where the plate was fixed, but the compression was not achieved. With the result, the plate broke down, and it had to be done this time, making sure that we got adequate compression at the fracture site. I thought of applying compression by using the clamp, but thought that the TBI is too big. So ultimately, I settled on this apparatus, which apparently is not being used as much as it was used about 20 years ago. The articulated compression clamp is a device which can apply compression across the fracture site. Once the fracture is well reduced, this is the plane. It is now recommended that if you want to apply compression to a large bone like a femur or tibia, or in some cases radius and ulna, one should not depend on the compression generated by the DCP, but one should use a compression device, articulated compression clamp, and use it. Of late, I have been noticing that younger people don't use it, but this should be reminded, and it should be used as and when it is indicated. This is just a method of showing it. And this patient, I did apply that clamp, and what I got at 4 weeks, there was adequate amount of callus formation. Because I was, with all that compression, I was able to generate relative stability, not absolute stability in spite of the clamp, relative stability, but that achieved my goal of seeing callus in shortest possible time. So there is the advantage of using these apparatuses in long bones. When you nail, what is really done is to achieve adequate stability through 3-point fixation. There is a misunderstanding that interlocking produces stability. Interlocking produces alignment, it maintains its length of the bone, it also guards against the rotational instability. However, the axial stability is not guaranteed by interlocking. For axial stability, which is the main force, one has to achieve a 3-point fixation. The 2 points fixation are the 2 interlocking areas, not the screws, but the areas. One should have adequate hold in the bone proximally and distally, and in the medullary cavity at some point, as soon as the fracture is loaded, the medullary cavity touches the nail and gets the 3rd point of fixation, and thus a 3-point fixation is created. So once that happens, like it is happening here, is well-filled cavity, good fixation early happening. While you see this example in this, the nail is so thin that there is hardly any contact on loading, and it went into a non-union. What you can see is close up that there is a large gap. So there is no way it could get a 3rd point of fixation, no 3-point fixation. So it went to this thing. A thicker nail was placed and there was no bone grafting, appropriate level was achieved. If you take a closer look, now the medullary cavity is well filled with this thicker nail. There is a lot of misunderstanding saying that when we ream, the intramedullary contents work as bone graft at the fracture site. It is difficult to imagine how through the non-union site, the medullary contents will go out and work as a fraction. So that really does not happen. What happens after a replacement nail is you use a thicker nail which establishes the contact with the medullary cavity and thus gets a 3-point fixation, which is the most desirable, and immediately the bone healing process starts. If you construct a very stiff, if you create a very stiff contact, there will not be any motion at the fracture site, so you will not see a callus. Here, passing a screw through a plate is the ultimate method of producing absolute stability, and that has been done in the tibia. But vicariously, you can observe that fibula that was not fixed also got stabilized by relative stability. And because of that relative stability, it's still abundant callus, which is well seen at the green arrow and behind the red arrow. So this is relative stability, which was vicariously obtained, and absolute stability, which was heterogeneically obtained. And you can see the two effects: no callus on one side, abundant callus at the other side. Absolute stability, relative stability. This is the example which you might have seen before. Uh, these are all locking screws, and so many of them have been used in the enthusiasm, with the result at the fracture site there was hardly any interfragmentary motion, no callus formed, and in good time the plate fatigued and broke. So to overcome this, the simple thing was done. A similar plate was applied, however with lesser number of screws. So there was some amount, or rather the adequate amount of motion in the fracture at the fracture site. Interfragmentary motion was involved. It produced callus, and the healing took place. No bone grafting was required when reasonable amount of strain is developed at the fracture site. If you do a suboptimal fixation, then also trouble starts. Here is the case at 24 weeks of plating. There was very poor callus formation, and the plate was hurting the patient, so it was taken out, and the arm was immobilized in a Sarmiento type brace for some time. But at 52 weeks, still there was inadequate callus formation. So at this time, what was done was use a longer plate than what it was originally used, and adequate compression was generated, but there was no bone graft. As soon as the strain levels were improved at the fracture site, the existing tissue started producing callus, and at 10 months you could see a very good strong union. The point I'm making is that if you generate enough stability, that will give you a useful interfragmentary motion at the fracture site. The tissue, the existing tissue around that bone will start producing callus, and very rarely one really requires additional bone grafting. Simply adjusting the strain levels will do the trick. And as a surgeons, we all know how to do that. Even in Kirillizarov, the same principle. We readjust this and then compress that so that the strain level is down to 2 to 10%, and the bone starts healing by compression. However, when this is optimizing the interfragmental motion to 2 to 10%, that is what is done there. And in distraction also, the distraction is carried out at 1 millimeter a day. The similar strain levels are produced and the callus is formed. If we hurry it up and distract is too fast, then the callus does not form, the new bone does not form. The same principle works of reducing the strain levels at the fracture line in Elizarov as well. You can see very well how the things are. So the long and short of it is that when we do an internal fixation, what we want to do is to make sure that there is some motion at the fracture site, and the way we can get useful interfragmentary motion at the fracture site is by creating relative stability. And that is the reason why we do an internal fixation. So there will be a change of topic. So far, if anybody has a question on what I have just said, I should be able to answer that.
I have a question, sir.
Yes.
Hello.
Yes, I can hear you.
Yes, sir. You show the one example of tibia fracture in which plating is there. So why can't we do the simple nailing in the mid shaft tibia fracture for relative stability?
We can do whatever we feel confident about. Plates are plates, nails are nails. If you do a nailing properly, there is no reason why you should not do it. But plate is also another method of doing things, and one as a surgeon should know both nail as well as plate and use whatever one feels confident. As long as when you nail, you make sure that you are creating a relative stability and some interference motion of 2 to 10% is available there. And also there is a 3-point fixation available possible, then nailing will also work equally well. It's not why not this, why not that, but whenever you choose or whosoever chooses to use it, this is the way to go.
Okay.
Any other question?
Good afternoon.
Abhinav, go ahead. Abhinav, go ahead for question.
Yes, sir. Sir, I have a question that how do we adjust the strain level and how do we calculate the strain level while fixing any fracture, and how do we judge the strain level which is to be required for a good calf and good healing of the fracture?
Yeah, there is no measure or no meter to calculate a strain level. In laboratory we can, but here in practice it is impossible. So this terminology of strain is basically to make us understand that there is some physics involved in that, and we should work to reduce the movement at the fracture site, but not eliminate it completely. That how much movement is beneficial to the patient, how much is the, or too much is not beneficial or detrimental, that is the judgment. That's why we take years to find out exactly what is what and how many where. So there is no
One request
hard
to
and
all the
fast.
delegates.
It comes by experience.
One request to all the delegates. Keep their mic muted. Only person who is asking questions should do it.
Can I, sir,
Yeah.
sir, can I ask the question, Dr. Thakur here?
Yes,
Yes.
sir, go ahead.
Sure.
Thakur, sir,
Haji.
on the problem with the surgeon is, particularly with the distal femur,
Yes.
intraoperatively, when he does the fixation, he doesn't know how much strain he has achieved, how much fixation, whether it is a optimum or not. Is there
Yes.
any way to see in the follow-up X-ray to change the mind and do a second procedure to get the same strain level, which is not cannot be calculated intraoperatively in the first surgery? How the surgeon can know that my strain level is there?
Yeah, it is by experience, and there are certain guidelines like in the lower end of femur, your plate should be long enough, and usually the question is long enough is how long enough. The scale for that is one should have 9 holes above the fracture line.
Okay.
In those field cases, majority of them do not have 9 holes of the plate above the fracture line. They either is short or long or something, but this guideline is not very well known, but it exists that if you use a plate long enough, 9 holes above the fracture line, then it will work. Then next is fix. There is another way. If you should do it that the way, and then wait and watch it for about 4 weeks. At the end of 4 weeks, if you do not find there is adequate callus formation, then you should take the second step of doing a second plating now on the medial side. And at that time, you may add bone graft, you may not add bone graft. There is a bone.
Can we take opinion of Dr. GSK on this?
Sir, even sir, can I have a one input?
Yeah,
We have, if once we have choose the longer plate, even though it fails many times.
Yeah.
We are talking generally on case
Okay.
basis. One can discuss.
Let GSK sir respond to this.
Yeah.
Can I talk? Yeah.
Sure.
See, working length is also another very important point to have this proper strain. The working length is more the working length, the strain level can be controlled. Now, how do you judge the working length? It depends upon the length of the fracture zone. If the fracture zone is more than 4 to 6 centimeters, then you leave 1 or 2 holes near the fracture site and then start the put. So the working length you have to work. The too short working length will cause too much strain at the fracture site, at the center of the plate. So working length is also very, very important point in judging this strain. So if there is a short zone, fracture zone, then you leave 2 or 3 holes. If the long work zone, fracture zone, you leave only one hole and then start the proximal fixation.
Okay, there is another
Now,
question.
in a long plate, you use only 3 or 4 screws. If you use more screws, it becomes more strenuous. Yes, Anand, do you agree?
Yeah, there is more on this topic in the presentation. I wanted just the questions on the first part that we had discussed. Clinical part will take it later, but I generally agree with what you are saying. I always agree with you, whatever.
Right. So do we go ahead at this point of time?
Sorry, shall we go ahead?
Yeah, we go ahead with the further illustration.
Sure. Okay.
All those who want to ask question have at the end enough time for question. So I will request all of you to please keep your mic muted. I am also muting my mic. Please keep your mic muted so that we can hear very nicely. Thakur sir, you can go ahead.
So what are the factors that dictate interfragmentary motion? It's the material of the plate, it is its geometry, it is the working length and the screw spacing, and also plate bone offset. Now let's take one by after. The material choice, titanium has a lower modulus of elasticity, and that's why it produces more, it's more flexible and is likely to produce more motion at the fracture site. However, the additional benefit that it is bacterial resistance, but it also produces cold welding. So there are advantages of titanium. It is also expensive and etc. etc. But as a choice of material, titanium is superior to stainless steel. However, stainless steel is time tested, economical, and it could, if we use our information correctly, we can still use stainless steel to produce the same degree of interfragmentary motion as produced by titanium by simply reducing the thickness of the plate. Usually the rule is that if you are using a 2 millimeter rod of titanium, instead you use 1 millimeter rod of stainless steel, the flexibility or the tensions, they are similar. So one need not throw away stainless steel. One should take it in mind, but when we should also know what are the advantages of titanium as that. And its flexibility, as I said, can be modulated when we want to do it. In such a person where the risks are high, the loads are very heavy, one feels more confident using a stainless steel material so that there is stability and the healing takes place without any problem. So both materials are good, but we have their own places to go through. A thin plate is naturally more flexible, so it is permitting more movement at the fracture site. The thick plate will not be as flexible, so that's a sensible thing to do. Use the thin or thick depending on what you want on that time. In log plate, the movement occurs only when it bends. As you can see, the screws are locked into the plate material and there is no movement between screw and the plate. The plate can only bend at this point, and depending on what is the length of this, what is this length, the stability will be affected. If the screws are too close, there will be less movement. If this is a very short distance, there will be less movement. If this distance is longer, there will be more movement. So bending occurs only in the plate. The screws do not take part in any movement of the flare. So that's why the plate length matters. The longer the plate, more the flexibility. This is a case done by me in 1978, and the very small plate that I have used in 2016, I have used the same thing, a longer plate. Why longer plates are common? Why they are popular? Because the longer plate is more flexible than a shorter plate. That's why we want a longer plate. And the other thing is How much long it depends on the fracture site or fracture geometry. If there is a comminuted fracture, then we use a plate 3 times longer. If it's a simple one, we use 9 times longer. By going by example, the fracture length is about 7.7 and used plate 23 point, about 3 times 23 centimeter. This here 23.7 centimeters. So longer is this 3 times the fracture length. If it's a transverse fracture, a very short oblique, then we go by 16 times. So, by and large, what we go for is a longer plate than shorter. If in doubt, use a longer one. Longer, the better. Longer, the long plate facilitates dispersal of the screw. We can spread out the screws. As we spread out the screws, the plate holds stronger as spread it out. And when it is the screws are far away placed, then the pull-out strength is also reduced. They are held better and the screws do not pull out easily in a longer plate. I'll show you examples how it happens. Is a plate applied, very 2 screws are applied, and we go and apply a very small load of 10 millimeter, and this is what happens. And we apply the same plate, but now leave 2 screws in 2 holes between. So longer plate has been used, and we go ahead and apply more and more. Nothing much happens. We extrapolate these findings to the bone, and we have this thing. It goes away like this because there is hardly any distance between 2 screws, which increase the distance, and you can see very little force is there. So wider the screws are placed, stronger is the plate. So use longer plates for higher stability. That is the message, or that is the rule for using plates. That's why we are using longer plates than before. Now the plate, as I said, what plate length that matters is this, which is between the 2 screws. The distance between the 2 innermost locking screws dominates the bending of a plate. If they are far away, more plate will bend. If they are very close, then it will not bend. And this distance is, we call it as working length. There are no guidelines how to judge a working length. What is the best working length for a particular fracture? There are no guidelines in science whatsoever. So we had to do some experiments and find out how it is. We have left no gaps and using both sides and say, this is a hypothetical number, we get a 34 and we get a interfragmentary motion, something like the bending will allow you this kind of motion. So we do this second thing, that we increase it to 70. We have left 1 screw on either side, the gap is become 70. Now almost it has doubled. So we become ambitious and we do the third one, and it goes through the roof, 106. We have left 2 screws and it goes down. So we can say go on like this and we'll get n number of interfragment, whatever you want, you can achieve. Now it's a little bit tricky. There are 3 components of interfragmentary motion: axial, shear, and torsion. Now shear and torsion inhibit callus formation. It's only axial movement that will facilitate formation of callus. The other 2 components are detrimental to following canals. And unfortunately, what happens if you increase the working length, the shear motion, which is detrimental to callus formation, which will inhibit callus formation, increases far more than the axial motion. So if we go on increasing the working length, it becomes detrimental. It does not help us. It produces an unwanted element of shear, and that prevents formation of callus, and the plate breaks. So it has been worked out now that 2 empty holes on either side of a fracture line is the longest working length that maximizes useful interfragmentary motion. By increasing longer working length, we can have interfragmentary motion, but the shear component will go up and the callus formation will not be promoted, which will not be facilitated, it will be detrimental. So that extra movement, that interferometric motion will not be useful. Only with this, the useful IFN is only to this level. Here, an example, we have the fracture site is here, and then 2 holes on this side, and then 2 holes on this side. So you have the optimum working length, and you can see in good time, excellent healing, and everything was satisfactory. If you use something else like this, a huge fracture gap, a huge working length here, it may be stable at that time, but this working length is going to produce a lot of shear force, and the possibility of formation of callus is less because of the mechanical reasons, no other reason. Even if you put bone graft there, it's not going to work because it's not going to produce callus, but the mechanical environment is not correct. Then shear force is too much, it will not happen. And sure often you can predict that this is going to happen. So it is important to judge your working length by experience or by this rough guide, only guide. This is not a huge guide that 2 screw empty holes on either side. Then what do you do if you don't get it? So you have to do other jugglery there. But the working rule is that 2 on either side, that should work very well. Now, when we increase working length, we get interferometric motion. But the disadvantage is that there are strains or damaging forces at the screw side. At the screw bone interval, there are damaging forces. If you make 3 holes on either side, there will be more damaging. 4 holes, there will be other damage. So how do we control this damaging force that our plate does not loosen? You saw in that example of humerus, the 2 screws had just walked out. Why they walked out? Because they were extra strained that could not be controlled, and that damaged, and it worked out, didn't work well. So the strains which I am talking about, I am shown with these red marks. They are maximum at the first screw, second screw, at the proximal cortex, but there is some element of strain or deforming forces also on the fore cortex. So both these are taken, and how we can reduce these strains, which increase when we increase the working length, these strains become more prominent. So how can we control that? We can control that by arrangement of the screws that we call how to present, that we call by screw spacing. This is a new terminology, and it is the distance between the first 2 screws closest to the fracture site on either side of the fracture. By example, I will say that the screw spacing is the distance between the blue and the red arrows on either side. That is the screw spacing. So if we change the distance between the first 2 screws, or between those red and blue arrows to some extent, then we will be able to mitigate the deforming forces, the strain levels at the near cortex and the far cortex, and thus prevent the loosening of a locking plate. How do we do that? Again, there are no hard and fast rules, only by experimentation. Managing screw spacing will reduce our strain levels. Now here, let me explain. We have taken the maximum working length and left 2 screw holes on either side. So this is our maximum working length permissible. And now we have taken number 3 and number 4 screw, number 3 and number 4 screw, and the last screw, which happens to be number 9. In any plating, the last screw is mandatory. You have to fix the last screws. We can't leave the last screws there. So our screw spacing here is 3, 4, and 9. And you can see the strain levels are going very high. And these are again arbitrary numbers, but you can just remember that they are high numbers. So this is the first one would, one would immediately put the second one, and then like this. This is a very common configuration you will see in your day-to-day practice. 3, 4, and 9, and our strain levels are high. So we change it, and now we go 3, 5, and 9. 3, 5, and 9. And see what happens. The strain at number 2 and number 3 drop by almost 50%, 45% they're down, just by moving the screw by 1 hole. By screw spacing at 3, 5, we have reduced that very well. So this is the way to go. So we go ahead, and now this time 3, 6, and 9. We got two empty holes inside, and it's further down. Not as much by 49%, but certainly by another 20-30%, which is good. So the 3, 6, 9 is one which is showing very well. So we continue our experiment and say it's 3, 7, and 9. It's not working now because the number 3 is now facing more loads. It has gone up a little more. So what we can say is that 3, 6, 9 was the best way. The optimal screw spacing would be 3, 6, and 9. What that means is that we leave from the fracture line, we leave 2 holes to get the maximum working length. And then to protect this plate, we leave 2 holes after the first screw, and then we have the optimum finishing line. Then the third, mandatory, the last one there. So optimal screw spacing is here, 2 empty holes after first screw to reduce the risk of screw loosening. So whatever we discussed just now can be summarized that the 2 empty holes on either side will give you maximum interfragmentary motion, and two screw spacings. That means 2 empty holes after the first screw will give you minimum strain at the proximal and distal cortex of those locked screws. And this is the way to go. These 2 articles are highly recommended, and they are very tough to understand. They're complex articles, but they're worth a go. Otherwise, what you can do is to simplified version is available on this, and there are several original diagrams which are not on the article. They are available here to make the understanding easier in this publication. And between these 2 publications, we will have answers to most of the locking plate businesses. So there we are. This is a new topic, screw spacing and some guidelines for working length. So any questions on this, I could do that.
So can I ask a question, sir?
Yeah, Unmesh, go ahead.
Sir, so if you look at a radius and ulna, a mid-shaft radius ulna, so what number of screw holes you expect in a plate? So if you expect 3, 6, 9, it's going to be a very, very long plate. So I would probably ask you about radius ulna and the humerus. What is the average level of number of screw holes you would be putting on either side, and what number of plate holes you will be using?
Yeah, one cannot expect to use 9 hole.
Exactly.
1, 3, 4, 9 every time. And in radius and ulna, I would think 1 empty hole on either side would be adequate. And after that, after the first screw, I would leave 1 space because I will not have the 2 spaces available. So my screw spacing my working length will be 1 hole, and my screw spacing will be another hole, and then I'll use the last screw.
Okay, thank you, sir. Humerus? So humerus?
He's asking for humerus also.
Shall I go ahead?
Yep.
Yeah, he's asking for humerus also. Is any
In humerus is a different ball game. Humerus has very high rotational forces acting on it. When you lift the humerus against gravity, or you can say just with 1 kilogram weight in your hand, you are loading the shaft by almost your entire body weight. So then I would think a longer plate, as long as you can do. If one goes anterolateral, one can use a longer plate. My preference is usually for the posterior approach, but depending on the fracture side, I don't hesitate to go on either way, but I use as long a plate as possible. And then depending on the configuration, I will take at least 1 on either side. And then there is a gap and those things. But in humerus, I will use 4 screws on either side.
Thank you, sir.
Is rotational forces. As Kulkarni had just briefly mentioned about the number of screws, on any plating, 3 is minimum or optimum. 2 as we discussed, and 3 this way. 3 screws will prevent all the axial loading, or all axial deformation will be controlled by 3 screws. For rotational stability, you need to add the 4th screw. And the position of the 4th screw really does not matter. As long as there are 4 screws in a plate on one side, you have done the optimum to get things to prevent the rotational to get the rotational stability. 4 screws in a plate side in one side will give you optimum rotational stability, and 3 screws will give you axial stability. Number
Thank you.
more than that are usually superfluous. They do not add anything to the stability, but they damage the bone.
Yeah, thank you. Ashok,
Sir, can I ask for the humerus?
Naveen sir, go ahead with your question.
Yeah. The question is, we are doing anterior bridge plate with the long plate 12, 14 hole, and we are fixing 2 holes most proximal and 2 holes most distal. Still, it gives very good fixation and biological fixation and union. Is it okay for 2 holes on either side, 2 screws on either side?
See, bridge,
Dr. Sergio is going to demonstrate that on the Saturday on a Geo webinar on Saturday 4 to 6. Is working at the Brazil, and he used the technique of 2 screws on the either side.
it is risky to promote a technique saying just 2 screws on either side. 2 is the minimum number of screws that you need for a plate fixation. Never ever do a fixation with 1 screw on either side. That will be disaster. So 2 are minimum, but we always want to be safe and use 3 screws so that once fails, then you still have 2 screws doing it. And as luck would have it, or as the mechanics have it, the 3 screws also become optimum for the axial loading. Now, bridge plate is a different principle altogether. You are bypassing a old fracture which has gone into non-union or gap or something, and under the bridge you are going to add bone graft. So the method or the rules of dynamics that we just discussed.
No, sir. Can I interrupt you? It is for the fresh fracture. It is not for the non-union. It is for the fresh fracture.
A bridge plate for the front structure.
Yeah, anterior bridge plate for a fresh humerus fracture, comminuted fracture.
Okay, thank you, Naveen sir.
It's presently beyond me. I have to read that and then I can discuss.
Yeah, can we go ahead with the presentation, sir, so that we have questions at the end? Yeah.
Shall I go ahead?
Yeah, you go ahead with the lecture. We'll mute all our mics now. Sir would continue with his lecture and then the question answer at the end.
Okay, fine. I'll go ahead. So what we want to now discuss is we want to use a locking plate with a large fracture gap, small fracture gap, and no fracture gap. In this situation, what should be our placement of screws, or in other words, what should be our working length? Now, before we go there, I want to just discuss 2 terms. Is load bearing configuration, which is there is a fracture gap. Now, in this situation, entire load is transmitted through the plate. The bone does not carry any weight because there is no contact. So the entire structure, your construct is under heavy load. It is taking all the load of the limb and hence is likely to get destabilized and is a weaker structure. But if you have contact like this, then the majority of the load is transmitted along the bone. So bone takes majority or the maximum load. It is not under great strain. Basic thing about the gap. Now, first situation we are considering is that we have gap. What happens? I'm muted by the host.
No, you can continue. We are listening.
Go ahead, sir.
I'm getting message you are muted by the host.
No. It is for others.
Okay. So there is a large fracture gap, and if we use a very long working length, then this plate will be very flexible and it will be under very high stress and it will fatigue before the callus forms. So we want the plate to last longer. So we don't put a very long working length in a large fracture gap. We use it This is the example. A very large working length was provided. Callus didn't form. Other reason being why it didn't form was the shear force, for which I use this picture again, and it can break. So large fracture gap, the working length should not be large, but should be a short one. When we have the shorter one, this will be under lower stress and will get sooner or later will get callus formation. So it will ease off more early, and then there will not be any fracture gap. In this example, you can see there is adequate working length here. The screw has been used here and here. So it is adequate here, and this would succeed. So for a very large gap, use a small working length. Put the screws closer to the fracture line. When there is a large gap, you put it closer to the fracture line. There will be lower stresses on the plate. Here's the example. It's a large fracture bed, but this additional screw has done the help. Here's the fracture. The first screw is right here, so the fracture gap is small. He has reduced that to small working length, and it will work very well. If there's small fracture gap, what would you do? If you put the very close screws, then very short part of the plate will be available for bending. There will be very high stresses there, and since the callus formation, since the moment will be very less, the interfragmentary motion will be less, the callus formation will be delayed, and the plate will fatigue before the fracture joins, and that's why you will get a fracture. You'll see a fracture line like this. So a small fracture gap, you use a very short this thing, it will be disastrous. There will be high stresses. So use a longer working length. You give a larger gap, so the movement will be more, it will be more flexible, callus will form early, and there will be less strain. Also, when you have placed the screws too far away or farther away, then there is a large segment is available for bending. So it will not, the stresses will be distributed over a larger section. Here they are only concentrated in small one when it bends. Here it is distributed over larger section. So it will not fatigue easily. It will last longer till callus forms, and you will be safer. So if the gap is small, use a longer working length. This example, which is classic, everything is locking screw, no fracture, no place for it to bend, nothing is available, only the small segment. So it fatigued early and was treated by giving a large fracture gap. The stress was distributed over this larger portion, which was also available for bending, so that more interfragmentary motion available here, quicker callus formation, and earlier healing. Small fracture gap, use a longer working length. If there is a well-reduced fracture, what do we do? In well-reduced fracture, everything works. There is no major stress available. So all the stresses are taken care of, and it works very well. Whatever you do, it will work. You can see no major stresses, everything works in the locking plate. It is a well-reduced fracture, no special design, it healed very well without any problem. So when the reduction is there, it is a load sharing construct. The plate is taking very little load. So you are safe, you can use your whatever configuration you use, it will work. So factors we've seen that modulate the interfragmentary motion are titanium and stainless steel plates, the plate length and its thickness, and the working length of the screw thing. These we had studied. But when we apply to this fracture line, it is ineffective in many places, and most notable is in this situation. Whatever we try, it fails. So what shall we do hereafter? Well, we have ways to go ahead. We invented flexible screws. Flexible screws, as we described there, that locking screw only bends here. And when it bends at an angle, the near cortex does not move much. It doesn't, there is no movement at the near cortex. The maximum movement occurs at the far cortex. So because there is maximum movement at the far cortex in a long plate, the callus formation is also maximum at the far cortex and very minimal at the near cortex because there is no motion. Why there is no motion? Because the plate does not allow it. It flexes in such a way. So far cortex lasting was invented, in which, as you say, it is loaded, the screw bends. With every loading, the screw bends. This is a special type of screw which I'll talk to you in a second. You can notice that screw bends, and when it is put in a plate form, the entire plate bends, and this time the near cortex and far cortex are parallel. They are not bending at an angle, but they are parallel. So the intrafragmentary movement is equal on far side as well as on the near side. So best movement available, so we'll get good callus formation, so quicker healing. What does this flexible screw do? It enhances parallel interfragmentary motion. This is available in as again showing that parallel movement. This is resting and parallel movement. Both the things come together. So movement is equal on both sides on axial loading. Two screws were initially available, but this has been taken out of market. Now this one made by Zimmer is available. As you can see, it has got different variations, and this shaft is flexible, and this part abuts against the proximal cortex, gives the additional support. This is the flexible part, and only this section engages in the distal cortex. So under loading, this part moves and gives you the desired motion. Here is an example. At 8 weeks, you can see a huge amount of callus formation, which is a very satisfactory position. The screws could also be used in the humerus proximal side also. Unfortunately, when the screws are short, this does not work. It works only when the screws are longer, I think more than 35 or 40. So what do we do though? We invent something else. We go to a technical thing called impact damping by elastic fixation. What it really means that this time the hole in which we fix the screw has become more mobile. How it is a small piece of bone in which there are threads here, and this not piece of metal, not bone, and there are threads inside. This is a screw hole, and which is enclosed in silicone rubber of special hardness, and this packet is then inserted in a slot in the plate. The plate is otherwise like a normal plate, but now the screw hole is inserted here, and it will look something like this. This multiple holes. On each screw has got a packet or a sandwich of a silastic rubber and the metal plate inside. And it will take ordinary screws which we are using on day-to-day work, and it will get locked in this and will work like a dynamic plate. Only thing is now the movement will occur not in the screw shaft like in the flexible screw, but in the hole there will be some amount of movement in the hole, and this has been called as active plate. It enhances callus formation at the diaphyseal sites. This is very useful and advanced by symmetrical axial dynamization. Stimulates circumferential load, not on one side like you saw in the flexing screws. The circumferential callus yields faster and stronger healing than standard locking plate. These active plates are in clinical use, but in limited center. It is not freely available, but it should become once the results are out. 1 or 2 papers are available and it works. I have some, this is from animal, you can see going that way. This is the active plate. This callus is on all sides. This is a locking plate. This is only at the far cortex, which bears out its movement. And this is again. No, that was a human. It's a human bone, and this is a plate used. I got these pictures from somebody in Germany, Professor Agat. He has been using it, and this is what is possible. So the clinical trials are going on. Only you and me can't reach it, but someday I'm sure we'll have them available. And you can see at 24 weeks, you have callus formation on all sides. So faster and stronger healing compared to the standard locking plates can be made available by use of this active plate, which is again a variation. Before, I want to thank all my friends who have generously given me their x-rays for use in this presentation. In conclusion, I would say that we have discussed the plate material, we have discussed the plate geometry, we have discussed the working length and screw spacing to get the best out of a plate, and the flexible fixation of far cortex and active plate. The plate bone offset, I left it out on purpose. All locking plates are to be put at 2 millimeters. That is the premise all the engineers will take when they do experiments. They will say the plate has to be offset by 2 millimeters, not less, not more. If the plate is in contact with the bone, then the working length factors don't work. In locking plate, it doesn't work. So it has to be offset and maximum offset is 2 millimeters. So bone plate offset is taken as for granted for all calculations and all discussion. In clinical practice, it is not always the case, but if we try to get that offset, 2 millimeter offset every time, then we will be able to get better results with our plates. That should conclude my talk this afternoon. And if there are questions.
Thank you, sir. Thank you so much. And now we will take questions. Dr. Shyam, Ashok sir.
One question.
Yeah.
Question.
Yeah,
One
yeah.
question from me.
Go ahead, Umesh.
Sir, what's the use of a standard screw in a locking plate? Any use of that, or we should be avoiding completely a standard screw usage, like compression screw or a standard 4.5 screws?
What's the use of what screw?
Standard screws in a locking plate. Standard.
Now the plates are available with facilities with locking and non-locking. Most of the plates are available like that. And standard screws are useful, and the locking screws are also useful. There are situations where you would like to use standard screws, and you have to judge that. So there's no, initially all screws were all the plates were either locking and non-locking, and we had trouble. That's why they came up with the facility of using this one or that one. Basically, if the bone is weak, then one should insist on getting locking screws, locking plates. Otherwise, your discretion and use it whenever you want to use it. Otherwise, there is no special advantage of.
I suppose Dr. GSK sir is going to comment on this.
Yeah.
Please, sir.
Shall I have some comments?
Yeah, please, sir.
Sir, the far cortex there are many articles have come up now. Standard is that the far cortex is no more used today because it has got many failures. Anand, your comment?
Sorry?
Can you hear me?
Yeah, I can hear you.
Yeah. The far cortex is not, there are many articles which are against the far cortex because the results are not so good.
You mean the far cortex screw? The flexible screw you are talking, Zimmer screw?
No, far cortex screw.
Yeah, the special screw which I said, which I showed you, that is the one, no?
What sir is suggesting, the far cortex is now.
It is made by Zimmer and is called motion lock screw. Is that screw that you want to talk about?
I think so. Anyway, that's one we have to be very careful about using the far cortex screw.
You're talking about this screw?
Yeah.
This has been in market for almost now 8-9 years and it hasn't become popular. So obviously there are issues with that. That's why it's not very popular.
No, the far cortex screw, which one the Zimmer is produced.
Yeah, and this one was earlier marketed by Synthes. They have withdrawn it. This is marketed by Zimmer as motion lock, and it is available, but they have not become very popular at this moment.
Ashok, do we have any questions on the chat box? Can we take questions one by one?
Sir, I have a question for sir.
Go ahead.
Sir, any suggestions about the one cortex or two cortex locking in the most distal screws of the plate? Some advice is the distal most screw of the plate should be only one cortex screws, or some tell about two cortex, or it should be done in oblique way, or
Okay. Say one cortex screw is absolutely no. Whenever possible, always you buy cortical screws. Whether you are using a standard screw or a locking screw, go for bicortical fixation. Because if you use only one cortex, your hold is only 60 to 70%. 30% is offered by the last one. And about the distal end screw, uh,
Yeah, he's asking about the end screw, sir.
Hello.
Hello.
I think his video has become off, unfortunately.
Yeah, I think his
Uh,
laptop switched off, I guess.
yeah, I think somebody. I think he'll be locking in again. So, any other question? GSK sir is there. Other panelists are there.
Yes. Sir. My question is, there is a difference between the active plate and the far cortical screw fixation. In the active plate, there is no role of no problem with the length of the screw, while with the far cortex, it is a problem. And I don't think there are any major human studies for active plates.
GSK sir, you want to comment on the role of active plate?
We have no experience with active plate. It is not available in India. I don't think we should worry about the active plates. Still, it is not yet marketed properly, and we are not able to do it. I don't know whether it is done in by largely in other countries also. There are no more reports on the active plates. So what is
uh,
more important is
There are no
sir,
human studies. Human studies are not available.
GSK sir, what is your review about the end screw, the distal most screw of the plate?
that almost true. That is the last screw you mean.
Yes, sir.
The last screw, if you want to reduce the strain, you can put the last screw as a conventional screw. And there are hybrid use. There is a hybrid use. That means you can use conventional screws along with the locking screws if you want to reduce the strain. Because all screws, all locking screws the strain becomes too much. So you can use hybrid screws. There is one of the questions was there. I
Yes.
think we can use a combination of conventional screws and locking screws. What I want to discuss is the locking plate in distal femur. Should we add a dual plate on the medial side? Because I personally feel that the other dual plate, that is the medial plate, is very important. Anand himself has written in his book in the new edition that the medial side, which is the compression side, and the lateral side is the tension band side. So if you use a medial side, the tension side is 200 times the compression side. So it doesn't make any difference whether in the lateral function of the lateral plate. So I think one should add a small plate on the medial side. I would like to have Anand's comment on this.
But sir, can I comment? It depends on the size of the gap, whether it is required or not. When the size of the gap,
we have classified.
We have to quantify the size of the medial gap or combination.
Absolutely, we have classified the 4 types of medial wall. Type 1 is the medial wall is intact. It is comminuted, but the wall is intact. The type 2 is 1 to 2 centimeter gap, and type 3 is more than half is type 3. So if there is a gap, if there is the medial wall is intact type 1, then you just lateral plate would be all right. But if there is a more than 1 to 2 centimeter gap and there is a comminution, more severe comminution, it is better to add a plate on the medial side.
Yes, primarily.
Primarily, yes.
Yes.
Thank you, Naveen, for that question. Any other question on the chat box? Dr.
Can I ask one small question?
Yeah, Umesh,
Sir,
go ahead.
Any studies between the pull-out strength of an Indian locking screws and imported locking screws?
GSK sir, are you aware of any study in the...
I don't think there is any study, but we have used both, and I don't think there is any difference between them.
Yes, it
Do
does
you?
give equal good result, Umesh.
Yes, okay.
Yeah.
That's fine. Thank you.
Apart from the ease of using the locking mechanism.
Instrumentation. The
Right,
difference is the instrumentation.
Yes. They are exact. Every time they would match. But for our economy, resource poor situation, the Indian plates are also working fine.
Yeah, quality control is the only problem.
GSK sir, one question I would like to ask you. In a locking plate fixation, in a distal femur, we use all these principles. But in an oblique fracture, there are at times problems. In spite of all these principles.
Then simple oblique fracture, you mean?
Yes.
Yeah, simple oblique fracture, we should treat it as a compression method. We
That
should
should be
not
the compression.
a compression method. Use 2 lag screws passing through the fracture side at perpendicular to the oblique fracture, and then put a lateral locking plate.
That's perfect. Ashok, any question on the chat box?
Comminution, if there is a comminution, then only the problem arises.
Right.
In all comminutions, I feel that we are now using dual plate and with very good results.
Sir, can I add? We have an experience in this distal femur. If you do not want to add the medial plate, even the intramedullary nail and the plate combination is good enough to sustain.
Absolutely. I fully agree with that.
In place of the fibula as a strut graft, intramedullary nail will serve the purpose of giving the stability which is required.
You know, we have done that lot of cases. Sunil has done a lot of cases on intramedullary nail.
We
and
are also doing. We are also doing, sir.
Good. It works very well.
Any other question somebody wants to ask? Go ahead.
There was one question by Dr. Mudit Jain.
Yeah.
He says that should the closest screw on either side of the fracture be locking screw only, or they can be standard also? The closest screw to the fracture, should they be locking only?
GSK sir, the question is the closest screw from the fracture. Should it be a locking screw or a non-locking screw?
When you are using, it depends on the closest should be the locking screw. Closest to the fracture side should be the locking screw. The last screw may be a conventional screw.
Okay.
Always the nearby screw should be a locking screw.
But I think it should depend on the quality of the bone rather than a type of the screw used. It is dependent on the quality of bone. If the quality of bone is good, why one cannot use a simple screw, no locking screw?
No, when you are using a locking plate, but when there is a good bone quality, you can use a simple conventional plate also.
Yeah, but the question is in a good bone quality of the young patient, nearest screw should be locking or non-locking. Is there a difference of using? That was I think the question was asked by.
It should be a locking screw because the locking gives you more stable fixation than the conventional screw, especially in the distal femur.
No, he's not asking about specific bone. He's asking about the mechanics, whether in these plates, locking screw or non-locking screw will be better when nearest to the fracture site.
I personally feel that a locking screw is better.
Okay, sir.
Okay.
Any more questions, Dr. Suksham?
No other question as such currently.
Right.
Dr. Anand Thakur's laptop could not function at this moment. So
Yeah.
can we get him back on his phone so that we can wind up the session?
Sir, I have a question for Dr.
Hello.
Naveen Thakur.
Hello.
Yeah,
Yeah.
go ahead. Go ahead.
Sir, in distal femur intramedullary nail with plating, which type of nail you recommend? Elastic nailing?
No, not elastic nailing is okay, but routine, when there is a combination, too much combination, then you routine distal femur nail, a distal plate.
Okay, okay.
Can you understand what I am saying?
Yes, sir. Yes, sir. But is there any difficulty of passing? First, you pass the nail or plate?
First, you pass the nail, then if it is possible, pass the locking screw through the plate, through the nail, and also
Okay.
proximally through the plate, through the nail. Then it
Okay.
gives the one assembly and it gives a very good fixation, and many times you do not require the bone graft. And if it is required, it is required after 6 to 8 weeks.
Okay, sir.
Any other question somebody wants to ask?
Hello.
Yes, go ahead.
Sir, if we apply a compression device, can we get a relative stability?
So you are asking for a fresh fracture?
Yes, in primary fracture, if you apply a compression device and then plate it, can we get a relative stability? Or it will be a...
I think we'll take opinion of GSK, sir.
Yes, what is the question? Please repeat.
The question is, if we use a compression device in a transverse fracture, can we get a relative stability or will it be an absolute stability?
No, you see, when you want to do, there are two questions. One is, when you are doing compression, you should use a compression method. Why do you want to use, when you are transverse fracture, you can use elastic fixation in humerus only. In other, it doesn't work well. In humerus, you can use a transverse fracture without compression, two screws distally, two screws proximally, what is called a biological plating. But when you are using a compression device, you should put a compression plate, what is called a protection plate or a neutralization plate. Don't confuse the issues. When you are using transverse fracture, you are using a compression method and you put a compression plate, that is the neutralization or a protection plate. I think
I think he is confused. The questioner is confused. When you want a compression, you do not require relative stability. Questioner is confused probably.
Actually, the sir, Anand sir has shown some x-rays with the compression device and he was saying he has got the relative stability.
No. When there is a gap, you cannot compress, and when there is no gap, you cannot have you can use any method. He said that without the gap, any method will work, any screw configuration will work. When you are closing the gap with the compression device, then there is no issue of stability, relative or that stability. When there is a good bone-to-bone contact, there is not much strain on the implant itself. That he has shown very effectively. I think so.
Okay, sir.
Thakur sir is joining back.
Yeah, let him join back so that we can
We'll wait for
him. By the time any chat box question, if it is there, or any question from the PG groups, let us take those questions.
Sir, sometimes in distal femur with the lateral DFLCP, some people use elastic nail or recon plate as a lost implant for medial side.
Yeah.
What's your take on for this?
Dr. GSK sir would answer this question because at Miraj they are using a medial enders nail quite often.
Yeah, we know for a distal femur, when there is a comminuted fracture, the medial side plate and a nail, we have compared both. We have used Ender's nail, initially two Ender's nail passing from medial side into the femoral canal, and now we are using the plate by MIPO technique. 2 or 3 screws in the distal fragment and 2 screws at the proximal shaft. So that works very well. Is that the question?
Welcome back, sir.
Hello.
Yeah, hello, welcome back.
I can hear you but can't see anything. Anyway.
Yeah, we are seeing you, no problem. You are fine.
All right.
We are well adjusted. So that was a wonderful lecture, and we had a lot of questions. If anybody wants to ask question, Dr. Thakur is back again.
Dr. Shivshankar is here.
He wants to ask, yeah.
Hello, good afternoon.
Okay. Shivshankar sir, you have any comments or something to add? I think he's not.
Can I ask the question, Thakur sir?
Sure. I am
Yes,
listening.
sir. I think in active plate,
Yeah.
the screw length is not the issue. That was the issue with the far cortical locking screw.
Yes. Yeah,
Screw
you're
length-
right. The active plate came into being because the far cortex flexibility is not there in a very short screw. It has to
Okay.
have adequate length. That's why they invented the active plate.
Sir, is there any human studies available? Large
Yeah,
human studies?
they are being used in selected centers. The last X-ray that I showed is of a human humerus, and that has come straight from the inventor only, Botlang and Peter Agat. I wrote to them, and they were good enough to give me that X-ray. So they are being used. Only thing, you and me can't get them at the moment.
Okay.
Hopefully, in near future, when FDA approves it,
What that plastic material they use?
I think secret, but what they describe it is as a silasticated rubber silastic compound. That is what they say, and it is fairly common material available, but they have their special brand.
We have to check for reaction to that material to human beings.
That's all been done. It has been partly cleared by FDA for human use. That means that all part has been done.
Okay, sir.
It is not in a experimental stage. It is a clinical trial stage now. Only thing not available to you and me.
Dr. Asim Negi, any questions from your side from Indore?
Sorry.
So any other question, Ashok, you have on the chat box?
There are a few questions in the chat box.
You can take
One is by Dr. Arun. What is the opinion about dual plating on unstable distal femur fractures with respect to locking plates? Dual plating.
Yeah, I have view on that. It could be done, but not at the primary setting. What is recommended is that you should go ahead and do your standard plating and watch him at for a month or so. At the end of 1 month or 6 weeks, if you find that there is not adequate callus formation, then you should go for the second time and then do plating on the medial side. At the same time, add grafts. But there is a strong recommendation not to do that at the first instance. As a primary case, one should not do a dual plating of femur. It causes more complications.
Right.
Any other?
In the same article or in the same study, they have specified the length of the plate should be at least 9 holes above the fracture line. In the shaft, we always have argument whether the plate was long enough or not. The only standard or measure available is this, that 9 holes above the fracture line is the adequate length.
There is another question by Dr. Gopal. He asked, what is the role of interfragmentary screw concept now with respect to locking plates?
Oh, I mean, there are two different things here. We can't compare apples and this thing. Interfragmentary screw has its role, and every time that you pass a screw across the fracture line, it should be lagged so that the fixation is good. If you don't lag it, then it will act as an obstacle and cause a non-union at that side. The use of lag screw through a locking plate is far-fetched. One would avoid that because it's difficult to put in the first place and usually not required. So they're not compatible questions. A trick question, I would put it.
Right. There is another question by Dr. Jain. He says, what is the screw spacing difference between short oblique versus comminuted fractures?
Screw spacing has nothing to do with working with the geometry of the fracture. Screw spacing is for making sure that your plate does not become loose, because when you are using a long working length, then there are stresses on the proximal screw bone junction, and that may lead to loosening of this plate. To avoid that, we use the mechanism of screw spacing, which is not putting the second screw immediately after your first one, but give a gap 1 or 2 and then put that one. That is the screw spacing. If you follow that trick or you follow that method of insertion, then your plate will be more will survive longer, because there are no deforming forces, no strains on the proximal cortex. So screw spacing is a new device, and one should use it so that your plates are they last longer.
Any other question?
Sir, can I ask the question?
Yeah, please go ahead.
Sir, regarding the same question I had asked, if it is a transverse fracture or if it is a comminuted fracture, the when we apply plate, the screw near the fracture site, we leave 1 or 2 holes in the transverse fracture, and we should leave less space in the comminuted fracture. Is it like that? Have a relative stable fixation in comminuted fracture. Is it like that, or?
It depends on the length of the comminution. If it is a long length, say 5, 6, 7 centimeters, then I would put it very close to the fracture site. One solid piece of bone where my screw will hold, I'll put it close to that. But if it's a transverse fracture, the bone is taking a lot of load, then my plate is quite safe. I can go very close to the fracture line, just leave one hole and then apply that. I will also, in transverse fracture, I will be careful to apply a strong compression, either through the DCP mechanism or by using a compression device, which I showed you, or in a smaller bone, use a Verbruch clamp and apply some additional compression to establish my fixation. But smaller combination, I wouldn't do much. One screw hole would be more than adequate. One has to react to the actual situation than the hypothetical one.
Right. Ashok, do we have more questions?
No, I think that is all the questions that we have.
Yeah. Thank you. Thank you very much, sir. We had a wonderful lecture, wonderful insight into the locking plate principles, and the interaction was also good. Thank you, GSK sir, for giving your expert comments. I hope during this lockdown period, we continue with this activity with the facility Dr. Ashok is providing us, so that we can have more and more interactions. Thank you, everyone. Thank you, Ashok, particularly for providing this platform. And we are so happy that we can discuss real orthopedic scenarios in the platform. Thank you so much.
Anand.
Thank you. Thank you, everybody.
Yeah, GSK sir, go ahead.
See, Anand, your talk was very, very excellent. We have learned a lot from you.
Thank you.
Very nice. Thank you very much.
You are always very kind to me.
I know.
Fantastic, sir. Fantastic, sir.
Fantastic.
Thank you. Thank you. Thank you. Thank you for all of you.
Enjoyed fully, sir.
Listening to me in the afternoon instead of going to sleep. You are listening to me. That is a lot of appreciation. Thank you.
Yes,
Listening to you
sir.
is always a pleasure, sir.
Always a pleasure, sir.
Yeah.
Original author, sir.
Yeah.
Original author, sir.
Original author.
Yes.
Okay. Thanks, everybody.
So
Thank you, Rajendra.
Thank you, sir.
Thank you, Rajendra. Thank you.
Thank you, Chandak, sir. Thank you. Thank you.
Thank you, Ashok. Ashok, you have done a good job.
Yes.
Thank you, sir.
Thank you. Thank you very much, sir. Thank you. Naveen, sir, you are switching over to GOA now? Go on.
Sir,
No, it's tomorrow.
Tomorrow, it is not today, sir. We have kept one day because it was initial part. Now it is almost every day.
Achha, today is not there. Okay.
Today is not there. Today is not there.
Please go on providing the link so that we can join.
And I have provided already pediatric link, tomorrow's link. I have provided you, sir.
Right, absolutely.
Webinar 3.
Right, thank you so
Oh,
much. Ashok,
okay.
are you dealing from the live YouTube?
Any what? Sorry?
Can we dealing from the live YouTube presentation?
Yeah, we can.
You can,